Good morning. Ladies and gentlemen, thank you for being here this morning. I'd like to welcome everyone to the Military Personnel Subcommittee hearing. Today we'll be just hearing from the Veteran Service Organizations and on behalf of the issue of Military Health System Overview and Defense Health Program Cost Efficiencies. And this is the beneficiary perspective. This morning the subcommittee meets to hear the testimony on the military health system and the Department of Defense's proposed cost-saving initiatives from the beneficiary perspective. I understand this is an unusually early time, actually 7 a.m. Standard Time, but thank goodness we've moved ahead. For Military Personnel Subcommittee to hold a hearing, and I appreciate everyone's willingness to be here this morning to discuss this important subject. For several years, the Department of Defense has raised concerns about the rising cost of health care and the challenge of maintaining the viability of the military health system over the long term. We must seek reasonable solutions for ensuring the availability of world-class health care, not only for our returning wounded and injured and their families and veterans, but to future generations of brave young men and women who answer the call to serve our nation. The Department of Defense has proposed several measures aimed at reducing the cost of providing health care to our service members and their families and veterans. The plan is a more comprehensive approach than previous cost-cutting efforts. That being said, these proposals will affect not only beneficiaries, they will affect the people who support military health care, such as local pharmacists, hospital employees, and contractors. We are joined today by an outstanding panel consisting of representatives of several dedicated military service organizations and a representative of organizations that support the military health system. I look forward to hearing your views on the Department of Defense proposals. What do you support? What do you oppose? And do you recommend alternatives to the proposals that we may consider? Before I introduce our panel, let me offer Congresswoman Davis an opportunity to make her opening remarks.
Thank you, Mr. Chairman, and let me also welcome our beneficiary representatives today, Colonel Steve Strobridge, Master Chief Joseph Barnes, Rick Jones, Deidre Park-Holman, can see everybody, and Kathleen Mokler, Marshall Hanson. I also wanted to welcome Mary Cook, who's representing the U.S. Family Health Plans. Thank you for being here. As you all know, yesterday the subcommittee heard from Undersecretary of Defense for Personnel and Readiness, Dr. Stanley, Assistant Secretary of Defense for Health Affairs, Dr. Woodson, and the Surgeons General on their views on the status of the military health care system and their efforts to improve the care being provided to our servicemen and women, retirees, survivors, and their families. Today we'll hear firsthand from the folks who really make the most difference here, from those who are the beneficiaries of the system and the experience that they are having with the military health care system and their thoughts on the health care proposals put forth by the Department of Defense. As you all know, our country is facing difficult economic times, and we are now faced with making some hard decisions that could impact the lives of those who are currently serving and those who have served. I know that our beneficiary representatives here today understand the challenges that we face, as several have previously made sacrifices when they served in uniform or are family members of those serving or who have served. We need to work together to find a way forward that will continue to ensure the very, very best quality of care for those serving, especially those in harm's way, and to ensure that the benefit being provided remains sustainable into the future. I look forward to a productive dialogue this morning on your thoughts on how we can move forward. Thank you, Mr. Chairman.
Thank you, Ms. Davis. We have 7 witnesses today, which is a large panel. As such, I would respectfully remind the witnesses that we desire that you summarize to the greatest extent possible the high points of your written testimony to 2 minutes. I assure you that the written comments and statements will be made part of the hearing record. In addition, I ask unanimous consent to issue the following statements into the record. The statement from the Military Coalition, the statement from the Association of the United States Navy, the statement of the Veterans of Foreign Wars in the United States, and the statement representing the views of the Air Force Association, Air Force Women Officers Associated, Army Aviation Association of America, Association of the United States Army, Commissioned Officers Association of the U.S. Public Health Service, Incorporated, Chief Warrant and Warrant Officers Association of the U.S. Coast Guard, Enlisted Association of the National Guard of the United States, Iraq and Afghanistan Veterans of America, National Guard Association of the United States, Society of Medical Consultants to the Armed Forces, the U.S. Army Warrant Officers Association, and the U.S. Coast Guard Chief Petty Officers Association. Without objection, so ordered. Let us welcome the panel. Mr. Steve Strobridge, Director of Government Relations, Military Officers Association of America, Mr. Joe Barnes, the National Executive Director of the Fleet Reserve Association, and returning we have Mr. Rick Jones, Director of Government Relations of the National Association for Uniformed Services, Ms. Deidre Holloman, Executive Director of the Retired Enlisted Association, Ms. Kathy Moakler, Director of Government Relations for the National Military Family Association, Mr. Marshall Hanson, Director of Government Relations for the Reserve Officers Association, Ms. Mary Cook, Vice President, Johns Hopkins U.S. Family Health Plan, and Chair of the U.S. Family Health Plan Alliance. As we begin, today we'll be hearing from each of the witnesses, and then the members of the subcommittee will be asking their questions, and we will each, beginning with me, be subject to a 5-minute rule. And we have someone who's impartial, above repute. Jeanette James is going to be the timekeeper and scorekeeper. With that, we will begin right away with Mr. Strobridge.
Sure. Mr. Chairman, and Ranking Member Davis, members of the subcommittee, I'm here representing MOA, but 13 other military associations have asked to add their names to our statement and have submitted a statement for the record as indicated by the chairman. MOA has not taken the position that fees should never rise, but that Congress should establish principles in that regard to explicitly recognize that the bulk of what military people pay for their health care is paid up front in service and sacrifice. We're encouraged that the new DoD proposal does a far better job of acknowledging that than did those of several years ago. Our principal objection is to DoD's plan to index future TRICARE Prime increases to some undetermined health care index that they project to rise at 6.2% per year. In our view, the main problem is that current law leaves much of the fee setting to DoD's discretion. DoD went years proposing no changes, making beneficiaries believe that there wouldn't be any. Then a new secretary proposed tripling fees, which upset beneficiaries and implied that they had not earned their health care through their service. We have statutory guidelines for setting and adjusting basic pay, retired pay, survivor benefits, and most other military compensation elements. We believe strongly that the law should specify several principles on military health care. First, it should acknowledge, if only as a sense of Congress, that the military retirement and health care package is the primary offset for the extraordinary demands and sacrifices inherent in a multi-decade service career. Second, it should acknowledge that those decades of service and sacrifice constitute a very large prepaid premium for their health care and retirement, over and above what they pay in cash. Finally, it should explicitly acknowledge that extraordinary upfront premium in the adjustment process by limiting the percentage growth in TRICARE fees in any year to the percentage growth in military retired pay. In the meantime, MOA and the Military Coalition pledge our support to work with DoD and the subcommittee to find other ways to hold down military health cost growth. We believe much more can be done to encourage voluntary use of the mail-order pharmacy system, reduce costs of chronic conditions, reduce system duplication, and cut contracting and procurement costs, to name a few. Thank you very much for the time.
Thank you very much. Mr. Barnes.
Mr. Chairman, Ranking Member Davis, and members of the subcommittee, thank you for the opportunity to appear before you today. Military service is unlike any other career or occupation. and associated with this, and requirements associated with maintaining readiness, are fulfilling commitments to provide health care and other benefits for career personnel after retirement. FRA's reaction to drastic health care fee increase proposals from 2006 to 2008 included support for legislation that would shift oversight of these matters from DoD to Congress, and support for a Senate bill in the 110th Congress prohibiting fee adjustments from exceeding the annual consumer price index associated with retired pay COLAs. DoD's 2012 TRICARE Prime fee adjustments plan is more reasonable than past proposals. However, initial adjustments are only part of the plan, and our association is very concerned about the yet-to-be-determined baseline index for inflation in 2013 and beyond. FRA supports the elimination of copays for generic drugs via home delivery and notes that survivors and medically retired personnel are not impacted by the plan. There are also no active duty fee increases, no changes to TRICARE standard, and no additional TRICARE for Life fees. FRA agrees with GAO that management efficiencies and cost-saving initiatives can significantly offset higher health care costs, and our members ask that Congress find a permanent doc fix to pending cuts in Medicare physician reimbursement rates, which is essential to ensuring access to care for all beneficiaries, including those under TRICARE for Life. Thank you again for the opportunity to present our views.
Thank you very much. Mr. Jones.
Chairman Wilson, members of the subcommittee, thank you very much for the opportunity to present testimony this morning. The National Association for Uniformed Service asks Congress to hold the line. Our association is not alone in this request to hold the line. We do not speak for them, but we are pleased to stand with the millions of veterans who formed the American Legion, the Veterans of Foreign Wars, the MVETS, the Air Force Sergeants Association, Jewish War Veterans, to name a number of major associations representing the men and women who actually served in the armed forces and who also reject the Pentagon plan. Our country has asked a great deal from these former troops. They have responded, kept the faith, kept our strong defense. We are better today for it. At first look, the plan for TRICARE increases may indeed seem modest, as the Department has described. However, it's clear the plan is a nose in the tent, under the tent, a Trojan horse, designed to divide Congress and divide military associations' voices, and to start a rollout for substantial increases in TRICARE fees and copays. Defense Comptroller Robert Hale called the Pentagon plan a slow start, and then he said it's a way to get Congress and the military associations in agreement, and then we can roll out the rest of it. To achieve their plan, the Pentagon officials began with a public affairs attack that suggested that a pre-war fee, a cost for military health care at $19 billion and a rise currently to $52 billion was the fault of retirees. Gentlemen, we're at war. The cost of military health care will always increase during war. It's never been mentioned by the Pentagon. It's always the retirees. And it always will be costly unless we leave our troops on the field, which American veterans and those generations we hope to come later will never do while they breathe American air. Again, the blame for the dramatic rise in military health care costs is the war, not the retiree. Our members tell us it's hard to imagine really anything that can be so callously said and directed at their members as to hear the stories in the national media that depict the cost of retiree benefits as being responsible for threatening available funding for our national security. This benefit is a benefit that has been earned. It is for honorable military service, and for those who don't understand it, these benefits were earned the hard way. They are part of a moral contract. They are different from private sector, regular federal health care plans. They are they're provided in return for a career in military service. And for those outside this room who wish to compare military fees to other government programs and who do not understand the risk inherent in military service, allow me to point out that there is a stark difference between running in Reeboks or Rockports to catch a carpool and running in combat or desert boots to catch cover, protective cover. The National Association for Uniformed Services is certainly not comfortable with defense leadership actually suggesting to the public
the price we pay for health care is more than the value our nation received from those who served more than 20 years. All to start slowly and to gain a nose under the tent. Certainly, there are a number of lower priority programs that can be reduced. If cuts are needed to tighten the budget, there are things big and small that can be done. Our members understand this, yet they see resources fly out of the federal government for the Professional Golf Association, for a museum for the groundhog, Puxatawney Phil, for the Cowboy Museum, for other projects really too numerous to list. Money was even directed to the Grammy Association, an association of millionaire record producers, artists, and the like. As we see $120 billion stolen by fraudsters in various medical and social programs, we wonder why they point to an earned benefit. Incredibly, there are additional questionable priorities. What signal, for instance, is being sent when our government directs our nation's hospitals to pay the medical care costs for treating illegal aliens? Does illegal alien health care trump the health care benefit provided by those who give a lifetime protecting American freedom? We have faith in our leaders, but we're not blind. Before we begin whacking our military earned benefits, let us make certain that we use our best wisdom and select our most important programs over our lesser important ones. And let us not forget, we are at war. And should be pointed out that many of our military retirees are on fixed incomes. Many cannot afford even the modest, so-called modest, 13% increase in monthly expense. Lifetime health care is an earned benefit. And please consider, our members have not received a COLA over the past 2 years. Mr. Chairman, we thank you very much for your time, and thank you very much for the opportunity to bring our view to your panel.
Thank you, Mr. Jones. Ms. Deidre Holloman.
Good morning. Chairman Wilson, Ranking Member Davis, and distinguished members of the subcommittee. On behalf of TRIA, I too would like to thank you for the chance to quickly speak about these critical issues. Your questions concerning the administration's proposed defense health cost efficiencies, it is clear from both the testimony yesterday and already today that we all acknowledge that the primary mission of the military health system is readiness, and the cost of that mission must be paid by the entire nation. It should not be the responsibility of those who have served a career in the military. Obviously, the present proposals are not as appalling as previous ideas, and for that we are grateful. That does not mean, however, that we support all the proposals. It is not clear to TRIA or others which medical inflation index DoD is planning to use, but it is completely clear that, at least for now, DoD is using a compounding figure of 6.2%. In a short amount of time, that figure will dramatically eat into a retiree's earned retirement package. It would completely destroy the present purpose of the COLA for the retirement pay. TRIA is completely opposed to this part of the proposal, and we feel no assurance that if this change is made, more costs would not be added or more groups would not be included after Governor Balducci finishes his study. As you can tell from my written testimony, TRIA was planning to focus on the need to keep the U.S. Family Health Plan running in its present structure. However, since you have invited a representative of that fine program, let me simply state that we know how hard it is to get up and running any effective program. USFHP does a wonderful job for its beneficiaries. We should be very careful not to dislodge its smooth functioning. While, of course, we have focused on the new budget proposals, I do not wish to miss the chance of mentioning the continuing need to focus on our goal of a seamless transition for our wounded warriors transferring from DoD health care to VA health care. In particular, at this moment, both departments should be urged to coordinate their Wounded Warriors Caretakers program. Presently, the ending of DoD's program and the starting of the VA's program do not mesh. This really needs to be corrected. Thank you very much for your attention. I look forward to trying to answer any of your questions.
Thank you, Ms. Holloman. And I'd like to point out there appears to be a technical problem with the microphones, and so everyone needs to get a bit closer, beginning with Ms. Kathy Moakler.
Thank you, Mr. Wilson. The National Military Family Association appreciates the opportunity to speak with you about military families and a benefit that they consistently rate as important, military health care. We agree that DoD's proposed increase of prime enrollment fees for working-age military retirees and their families is fair. Our association has concerns, however, with using a civilian-based index in determining these fees after 2012, and we have always supported the use of the cost of living allowance as an index for increasing fees. While we agree that it can drive efficiencies through changing behavior, we do have some concerns with the proposed increase in copays for retail medications and the impact this increase will have on beneficiaries who have no choice but to rely on the retail pharmacy for urgent, non-maintenance medications. We should not penalize a military family when their child needs an antibiotic for pneumonia and they have no other option than the retail pharmacy. Family readiness calls for access to quality health care and mental health services. Military families may be encountering access challenges and provider shortages as we look ahead to the prospect of decreasing Medicare reimbursement fees, new contract renegotiations with the T3 contract, and the uncertainties faced by providers in regards to health care reform. We are pleased with the many resources that have been provided for families for non-medical counseling. We are concerned about a shortage of behavioral health providers in the MTFs and the network. While we know that the services are addressing this with new programs, we are troubled by the increases in service member suicides and also by the increase in suicide and suicide attempts by military family members. Our written statement goes into greater detail about these issues. Thank you for letting us be on the panel today.
Thank you, Ms. Moakler. And at this time, Mr. Marshall Hanson.
The Reserve Officers Association would like to thank Chairman Wilson, Ranking Member Davis, and members of the committee for today's invitation. Being brief, ROA finds DoD's proposal of a fee increase of $60 a year for TRICARE Prime families and half that for individuals a modest rise, and doesn't find the proposed increases for pharmacy copayments excessive. We hope that initial prescriptions at retail sites are exempted, though, permitting the beneficiary follow-up time to take advantage of mail-order savings. Where we hesitate is that DoD is suggesting an index for increasing TRICARE Prime fees in future years. While ROA would accept an index based on COLA, we also feel there is a need to explore other indices should a COLA basis not be accepted. The most important point of this hearing is to establish a process to involve Congress, the Beneficiary Association, and DoD in determining acceptable rates. Unilateral decisions by the Pentagon worry ROA members. While ROA was once open to a cards-on-the-table approach to health care discussions, we have grown hesitant by how the Pentagon implements programs. ROA is frustrated that DoD treats reserve component health care for drilling reservists as a health insurance program, even though reserve component members have mobilized over 800,000 times. And we are quite disappointed with the market-level premiums levied upon gray area retirees. We hope that the committee will agree to a GAO review on premiums for TRICARE Retired Reserve the same way the HASC prompted reductions in costs for TRICARE Reserve Select. Also, ROA asks that you look into DoD allowing TRS beneficiaries who are discharged the option of being in the Continued Health Care Benefit Plan. Selected reservists are the largest group in the United States not provided transitional COBRA protections. Lastly, we need to work with your staff to ensure that all Guard and Reserve members coming off of active duty are permitted a TAMP coverage. Some individuals are being told they are not covered. Thank you once again, and I am ready for questions.
Thank you, Mr. Hanson. And we'll now conclude with Ms. Mary Cook.
Thank you. Mr. Chairman, Representative Davis, and distinguished members of the subcommittee, thank you for the opportunity to testify today on behalf of the Uniformed Services Family Health Plan. I am honored to be here today to share this opportunity with my colleagues from the Military Beneficiary Associations who serve our nation's heroes and their families so well. U.S. Family Health Plan is proud to share in this commitment. My brief statement will focus on the successful partnership between U.S. Family Health Plan and the Department of Defense, and our concern that a proposal contained in the President's budget request, if enacted, would prohibit us from caring for many of our nation's heroes and their families. The President's budget proposal would end the U.S. Family Health Plan's ability to care for those beneficiaries who need it the most, and is designed to undermine this highly effective program. 30 years ago, the Congress directed that our organizations continue the tradition of providing health care to uniformed services beneficiaries, including those aged 65 and over. With the introduction of the TRICARE program, new legislation made us a permanent part of the military health system, establishing the U.S. Family Health Plan as a fully at-risk managed care model designed to provide comprehensive health care while maintaining cost neutrality. Today, the U.S. Family Health Plan provides the TRICARE Prime benefit to nearly 115,000 military beneficiaries in 16 states and the District of Columbia. The 6 not-for-profit healthcare organizations administering the U.S. Family Health Plan are Johns Hopkins, Martins Point Healthcare, Brighton Marine Health Center, St. Vincent's Catholic Medical Centers of New York, Christus Health, and Pacific Medical Centers. As a proud partner with the military health system, our objectives are aligned with the Department's stated goals, which include readiness, the patient's experience of care, population health, and controlling per capita costs. U.S. Family Health Plan continues to be the highest-rated health plan in the military health system. This year's independently administered satisfaction survey found that 91% of our members rated our program highly, as compared to only 62% of members in commercial managed care plans. With regard to cost, by statute, total payments for health care services to enrollees of the U.S. Family Health Plan cannot exceed an amount equal to what the government otherwise would have incurred had our enrollees received care from alternative sources, whether those sources be military treatment facilities, TRICARE, or Medicare. Because we are reimbursed on a capitated basis, our financial incentives are aligned with our longitudinal approach to population health, namely, to engage our members in living healthy lives and preventing chronic illnesses that both diminish quality of life and disproportionately contribute to escalating healthcare costs. Given our high level of beneficiary satisfaction and our success in adopting innovative strategies to improve health outcomes, we were disturbed that the President's budget proposes to require all new members to disenroll from our program at age 65, just when they need the benefits of our program the most. The proposal does not save the government any money. It would merely shift the cost of care for our older beneficiaries from the Department to Medicare. In doing so, military beneficiaries and their families who choose our plan, in large part due to our integrated approach to population health, would lose access to our highly effective prevention and medical management programs. It appears then that the budget proposal and its destabilizing impact on the U.S. Family Health Plan is in conflict with the stated goals of the military health system. Perhaps most concerning is the fact that over time, thousands of aging military beneficiaries who need our help in managing complicated medical conditions simply won't have access to it. We understand the challenges the Department and the Congress face in needing to reduce costs. But the elimination of innovative programs like the U.S. Family Health Plan is counter to the goal of reducing government health care costs. Accordingly, we urge Congress to reject this proposal and protect military families and retirees' access to the quality of care they like, need, and deserve. Thank you very much for the opportunity to be here today.
Thank you very much. And now we'll begin with the 5-minute rule, and Ms. James is very precise in this. And as we begin, I want to thank all of you, and I wish the American people could see the level of dedication of the veteran service organizations. You represent millions of members of families who have put their faith in you. And the organizations here today, the persons who provided the different organizations who provided statements are so helpful. And so you're the people who are the persons who have the background, and you're the people who use the systems we're talking about. It's also significant that it does not cost the taxpayers any money. So you're the correct example of stewardship. Yesterday we had an extraordinary hearing with Dr. Clifford Stanley and Dr. Jonathan Woodson, and Dr. Stanley is special to me. He's a graduate of South Carolina State University, one of the great universities of South Carolina. And so I really am frustrated that with their capabilities, that the President has named a military health care czar, the former governor of Maine, John Baldacci. We don't need a health care czar. We've got veteran service organizations that can provide this information, and as stewards of the taxpayers, this is not government's money, it's the taxpayers' money, $164,000 plus expenses, I think, are being diverted from the military health care system. It could be done without any expense, and I really think the first thing that the governor should do is step down. He could then create a savings of almost $200,000 by way of efficiencies. With that, indeed, we have people here today, and this is going to be tough. Each of you have 30 seconds to tell us how you would provide for an efficiency, beginning, obviously, with Mr. Strobridge.
Sir, I think there are a lot of opportunities for efficiencies. We have engaged with the Defense Department to a pretty significant degree on the mail-order pharmacy system. Despite what DOD has done so far, there's been really only a relatively modest shift. And what we've advised the Defense Department is they've probably gotten most of what they're going to get from people who are motivated by the money savings. Our surveys indicate people who aren't shifting so far are doing so because they are worried about one aspect or another. They're deterred from taking that step. And we've talked to the Department of Defense about giving people that information ahead of time. They haven't done that so far, but we've been trying to work with them to get the most frequently asked questions, get those answers to those people, which will reduce their inhibitions about calling to try it, because once people try the mail order system, they're pretty satisfied with it. We think that's a huge potential savings.
Thank you.
Mr. Chairman, I would echo Steve's comments with regard to the mail-order pharmacy. As I noted in our statement, we also note that GAO has identified several opportunities for significant savings, including command structure reorganization, which could save estimates of in excess of $260 million to over $400 million annually. Within the department. There are also opportunities with regard to greater interaction and coordination with the Department of Veterans Affairs with regard to electronic medical records. The ALTA and VISTA systems do not interact despite significant resources that have been committed by both departments to those programs over the years. It's kind of mind-boggling. FRA has questioned why the VISTA system was not the basis for developing the ALTA system, given the fact that we need to take care of our wounded warriors that transition from DOD to VA health care. So those are just a couple areas that we would recommend. Thank you.
Thank you.
Exactly right. I echo both of those thoughts, particularly the ALTA thing. ALTA comes in with rave reviews from the defense contractors, but the doctors seem to say it's a burdensome system. It's incompatible with VA, and DOD and VA have been working on finding a way to combine the electronic system for years. Charles Percy, senator from
Illinois.
Oh, gee, how we forgotten.
Illinois.
Senator from Illinois, long ago, 1982, began the process. He said, we need to pull this electronic health record together. I would also point out that there are opportunities for this sort of combination and joint working between VA and DOD in South Carolina, for example, in Charleston, South Carolina. There's a major veterans pharmaceutical distribution system right across the street from the hospital. We've sent people down there, and they had an oversight hearing last year at the House Veterans Affairs Committee, where there were problems in the mail order and distribution of pharmaceuticals, but it was pointed out that all you had to do was walk across the street to connect with VA to get this job done. So that's a major problem. Procurement reform is necessary in DOD. GAO pointed out several issues this past week in procurement reform. These are major issues and areas that we need to look at, and of course to incentivize the healthcare mail order system is important as well, can save a lot of money for beneficiaries, in particular, who we represent.
And to be fair, and I apologize, we need to go immediately to Ms. Davis, and so I'm subject to the 5 minutes too, obviously.
Thank you, Mr. Chairman. So why don't I let the rest of you finish with my time? Go ahead.
Quickly, of course, I agree with the suggestions already made. I think there should also be more of a focus on treating chronic illnesses. It has been discussed. It was discussed briefly, as all things were, yesterday, concerning the medical home and that pattern and that structure. Certainly the government is looking at that, but that should really be a major focus. As has been shown, it saves money, it accomplishes the purpose of the healthcare system. And USFHP is a prime example of how that works and how it saves money and improves lives.
We, of course, agree with all the previous efficiencies that have been introduced, but we'd like to reemphasize that establishing a unified joint medical command structure would certainly introduce many efficiencies. As you know, we're a purple organization, and we feel that families would be best served by a joint command, a joint medical command. We also encourage the inclusion of recommendations of the Task Force on the Future of Military Health Care in this year's NDAA, restructuring TMA to place greater emphasis on its acquisition role, examining and implementing strategies to ensure compliance with the principles of value-driven health care, reassessing requirements for purchase care contracts to determine whether more cost-effective strategies can be implemented, and removing the systemic obstacles to the use of more efficient and cost-effective contracting strategies.
Medical and dental readiness continues to be having a big impact on reserve component mobilization. And as Dr. Heck pointed out at yesterday's hearing, if reserve dentists and doctors were permitted to treat fellow reservists, this would save health dollars and help our nation's readiness.
And I would echo the comments of my colleague, Mrs. Holloman. The best way to decrease health care costs is to eliminate the medical conditions that diminish quality of life and contribute disproportionately to rising health care trends. So I would suggest an upfront investment in prevention and programs to minimize and eliminate chronic conditions as the long-term efficiency.
Excuse me. Thank you so much. I mean, I appreciate everybody. Maybe I just want to really focus on your comments, Ms. Cook, earlier, especially because I think there, as it was explained to us yesterday, there is a difference in the decapitated care, and so it's the capitated care, and so it's we're trying to really understand. I know prevention saves money. I believe that. When we've been looking at health care for the country, we've made that point repeatedly. Unfortunately, it doesn't score when you're trying to figure out what some of those best methods are, and that's a great frustration, even though that you know that you're going to be able to do that. Can you explain a little bit better then how your plan actually saves money, and how has that been documented over the years?
Yes, thank you for the opportunity. I will comment that the comments yesterday suggesting that there was a difference in cost, again, seems to us to be inconsistent with the law. And so we look forward to CBO scoring what this proposal would be, in that by law our costs cannot exceed what the government would pay. But with regard to managing chronic conditions, you know, the healthcare industry faces the problem of how do you quantify non-events? How do you quantify the fact that certain people would have gotten diabetes and otherwise today do not? Throughout the 6 programs, we have over 40 disease management and care management programs. And so I'll give an example of Johns Hopkins, who's very focused on research. We've got one program that's called Guided Care that embeds clinical staff nurses in primary care sites and provides them a panel of military retirees based on the chronic conditions that they have. And so there's been assessment that because of that program, which focuses on not only engaging the member, but visiting the member's home, engaging the family, understanding what community resources are, and actually developing a care plan for the military beneficiary that they keep on the refrigerator, with the clinical nurse sometimes accompanying them to specialty care services, has shown a decrease in costs with regard to repeat inpatient admissions, and has also shown an increase in satisfaction with the member and the provider.
My time is up, but perhaps in the next round we'll have a chance to come back, or someone else could ask about how, given all that, and I appreciate what you're saying because I believe that, but I also want you to show us how you could reduce costs if needed. Okay.
Thank you very much, Ms. Davis. We now have Dr. Joe Heck of Nevada.
Thank you, Mr. Chairman. You know, what we heard when the other panel was here was this analogy or the comment made about that they're talking about the working age retirees. So potentially somebody enlisted at the age of 18, retired at the age of 38, and what's going to happen from age 38 to, let's say, 65. And that individual may go on to a second career, maybe a very successful career, and be very well off. And whether or not there should be some responsibility on that person's part or their new employer's part to provide some of their health care coverage. I'd like for you to address the counter-argument and why that analogy doesn't really hold water.
Yes, sir. I think we'd like very much to address that. That's one of the problems I think we have with some of the DoD descriptions. You know, when they talk about working age retirees, there's almost an implication there that if you go out and get a job, then you didn't really earn your health care. And from the perspective of military people, they spend 20 or 30 years on active duty being told that if you put up with these conditions that other Americans aren't willing to put up with, then you will be provided a package of retirement benefits, including health care. And nobody in there said, oh, but that doesn't apply if you go get a civilian job. That is what gets military retirees so upset, because they fulfill all the conditions, all the extra sacrifices that the government imposes, and the government imposes no cap on the amount of sacrifices that they will extract. Once that service is rendered, all of a sudden, some folks in the administration want to seem to say, you know, that service has no value anymore. That, you know, if you get a civilian job, DOD has no employer responsibility to you, even though you served as a DOD employee under those conditions for 20 or 30 years. To us, that's very important. That's why I mentioned in my oral statement, we think it's very important to have some statement in law, where there is none now, that states explicitly that military health care is one of the crucial offsets to the adverse conditions of service, that it is in fact an upfront and very substantial premium payment, and that would help defeat some of these arguments, I think, up front, that people want to devalue the service and only compare cash to cash, which to us is an apple to orange comparison.
One of the arguments that we made for the existence of TRICARE Reserve Select was to improve the hireability of members of the Guard and Reserve by having a health care plan that is exportable, that would help small employers know that when they bring an individual in that they're bringing a health care plan with them. And this is one of the incentives that we have in place, because we're beginning to see problems with reemployment of people that have been deployed. And this same argument can be taken over to TRICARE for the active duty retirees as well, because here's an experienced working pool that is needed by this nation's economy, and if they have a TRICARE Health to bring with them as well, that means they can be hired by individuals who maybe couldn't afford equivalent people in the normal working place that didn't have a military background.
Mr. Heck, Robert Gates, Secretary of Defense, says these working retirees, as you described, are beneficiaries who are employed full-time while receiving full pensions, often foregoing their employer's health plan to remain on TRICARE. Well, it's apparent that some may find it very hard to understand, but the simple fact is that these men and women earned a retirement benefit, and they actually look forward to using it. It's a breach of moral contract to stunt that promise that's been made to these folks.
Dr. Heck, I would add that this issue goes to military service being unlike any other career or occupation. And there's a propensity to constantly focus on the dollar, the bottom line, and not on the commitment that was made and those that served in the past. Also, with regard to the enlisted force, those retired from the enlisted service, many of them do not have the high-paying jobs or the resources that are assumed when these discussions when these points are brought forward. Also, approximately 1% of the population is shouldering the responsibility for defending our nation, and the total amount of defense spending as a percentage of GDP is historically low during a wartime period compared to past periods of conflict. So a couple observations to add to the discussion here. Thank you.
Thank you, everyone. Indeed, Ms. James is really tough on this 5 minutes. I tell you, she punches me. You all don't see this. Congresswoman Nikki Tsongas of Massachusetts.
Thank you all for appearing before our committee today. It's an important issue, and I appreciate the insight that I'm receiving from each of your testimonies. Yesterday, in the first of this series of hearings, I said that before Congress could increase TRICARE fees for working-age retirees, any proposal on the table would have to be proven to minimize impact. It would be inexcusable in my mind to deprive our retired heroes of the health benefits they have earned. I also question the disparate impact of any increases on service members who accrue less annual retirement benefits than others. As you all know, retirement benefits vary greatly, depending on a number of factors, such as how long a person served and whether they were decorated for extraordinary heroism. The key metric, however, is the rank they hold or held. Retired generals can earn robust six-figure sums in annual retirement benefits, whereas enlisted personnel may only earn benefits in the teens. Yesterday, in the first part of this series, I asked Undersecretary Stanley and Assistant Secretary Woodson if the Department had seriously reviewed any proposals for a stepped increase of TRICARE prime fees for working-age retirees determined on the basis of rank at the time of retirement and retiree benefits earned. Assistant Secretary Woodson answered that the Department did not consider this proposal because it would be difficult to administer, since the Department would want to take into consideration retirees' other streams of revenue, a statement I do not agree with. More importantly, though, he stated that it was unnecessary in this case because the fee increases that were proposed are modest. But he stated that, quote, "If we were proposing large fee increases, I would agree with you strongly." My question then to all of you is, do you agree or disagree with Dr. Woodson's assessment? And if we could begin with you, Mr. Strobridge.
Yes. The Department, in fact, did propose tiering fee increases previously. The military coalition has been unanimous in opposing means testing of military benefits. We don't have that for federal civilian health care. The President pays the same as the low SGS employee. One of the concerns, I think, is creating a situation where the longer you serve and the more successfully you compete for promotion, the less your benefit is, and we don't think that's a good incentive. But more and more, it's, as I said in my oral statement, the military benefit package is considered the offset for the adverse conditions of service. You earn the package mainly by your service. And I would have to agree with the answer that was given yesterday. Once you start trying to split it, basically what you're saying is who can afford to do what. And I think they were accurate. Once you start to say who can afford to do what, you have to look at all your income, and it ultimately drives you to looking at last year's tax return. And to us, we don't think that ought to be based on what kind of job you get as a civilian. We don't think it ought to be based on what your spouse's income or how much you inherited from a parent. Your benefit derives from your service, not from your grade.
I would agree with Steve's comments. Also, I think the comparison issue between military benefits and federal civilian benefits is a real strong, compelling example with regard to that concept. There are also a number of variables, I think, and I was not at the hearing yesterday, but from your description, it sounds like the Department is referencing the complexities of administering that with regard to just retirement income or total household income or what have you with calculating that. So I go back to the equity issue, the connection, and looking at Federal benefits, and that's been our position, and we concur with the Coalition's position.
The Reserve Officers Association doesn't support a tiered approach based on rank, because it should be pointed out that reservists and Guards members have an income in their retirement that is 25% to 30% of what an active duty member does, because of the fact that they are part-time warriors. So it would be very unfair to charge someone in the reserves the same amount based on tiering that you would do an active duty member.
And we are at the 5-minute situation. Colonel Allen West of Florida.
Thank you, Mr. Chairman, Madam Ranking Member. And a few years ago, there was an Army commercial that said, we do more before 0900 than most people do all day. So thank you, Mr. Chairman, for bringing that commercial back to light. With that being said, you know, this panel and this briefing today is very important to me. It is very personal to me. I had a father who served in World War II. He was a disabled American veteran. My older brother in Vietnam, also a DAV. I did a couple of years in the Army myself, and now my young nephew is following my footsteps. My father-in-law served 2 tours in Vietnam, and my 2 brothers-in-law served also in the United States Air Force. So when I sit here today, I think about a quote from George Washington, and I'm paraphrasing, when he said that future generations of a nation will judge itself based upon how well we treat our veterans. So I think it is very important that we understand that what we're talking about here is not a benefit. It's something that people have been willing, when they raised their hand, that they were going to give their lives for. And I think that this nation owes them that. However, I will ask this question to you. You know, when I first retired, I would, you know, spend my Fridays going down to the VFW post. But I found myself not being able to endure that too much longer because, you know, myself being a very avid distance runner, the cigarette smoke was just absolutely choking me. So my question to each and every one of you today, we're talking about what has to be done on this side, but I think there's a responsibility also for those of us who have retired. And so how do we develop initiatives that incentivize healthy living in our military retirees? I think that's very important. So I'd like to get your thoughts on that. Thank you.
I think that the military health care system has already introduced some preventive care programs within the MTFs. And some of those will be, can be focused on diabetes, helping those who are pre-diabetic to keep from having full-blown diabetes. There are also programs aimed at weight loss and controlling obesity. And as a beneficiary myself, I have seen those programs offered within the MTFs. And also some of the TRICARE contractors are creating those programs as well. As with any benefit offered to our military service members, our retirees, our survivors, it's communicating the availability of these programs and ensuring that our families and our service members can take advantage of those programs.
I thoroughly agree. The military life, everyone thinks of it as a healthy life, and it's not. It's a fit life. People are fit, but they aren't all that healthy in some of the habits they develop, in large part because of the pressures of that life, smoking, alcohol consumption, other things that can really affect long-term health requirements. And I firmly agree that the MTF programs, the contractors programs, the programs, again, mentioned for the U.S. Family Health Plan, that sort of thing, should be a focus. And it, as Kathy Moakler said, it should be widely publicized. Because how many times do they say you have to say something before it gets in my head? I think 7 for ads. At least that's what Crest seems to run on. And I think we have to do the same thing.
Congressman West, I think one of the frustrating things is that there has been a lot of effort tried to put to that, sometimes to no avail. We actually had to get this subcommittee to pass legislation to get DOD to run a pilot program to have TRICARE pay for smoking cessation programs. And even then, we don't include Medicare eligibles in a lot of those incentive programs that we have, because as Ranking Member Davis points out, you end up with the scoring problems for Medicare eligibles and those kinds of things. So the budget rules actually inhibit us doing things that will encourage healthy lifestyles. Something else we think that needs to be done is eliminate the copays for those maintenance medications for people with chronic conditions. There are all kinds of studies out there that show that even a modest copay deters people from taking their medication. So there are lots of disincentives built into the system that I think we can still do. Unfortunately, it seems to often take a law change to get DOD to do those.
And we are precisely at 5 minutes, as I have been gently reminded by Ms. James. Next, and our subcommittee is so fortunate to have people with experience, and we have a former sergeant in the Army, a former major of the Marine Corps, Congressman Mike Kaufman of Colorado.
Thank you, Mr. Chairman. I've got a question about TRICARE fees, and why don't I start at this end for those groups that represent beneficiaries and go the other way. And I think here's my question. Would your organization support the proposed increase, $30 for individuals, $60 for family annually, if it were tied to a retired pay cost of living adjustment, vice Medicare? And for those who say no, what if the increase didn't impact current retirees? What if it were grandfathered in and didn't start for 2 years? Just different iterations of the same question. But the primary thing is going to this about limiting the adjustment to whether or not there's a cost of living increase. So if the cost of living increase were 1% or there wasn't one, then it would be limited to the 1% if that were the case, as opposed to whatever medical inflation was. Let's start with Reserve Officers Association.
Thank you, Congressman. In short, a combination of the modest increases this year with an index based on COLA is something that ROA could not object to. The one concern that I have with how you phrase things is the setting up of generational differences in benefits to where one group is grandfathered and the next is charged more. That should be uniform across all people who serve.
I agree with Marshall Hanson on that. Our association has agreed to the increase in fees even when they were first, the principle of increase in fees, even when they were introduced 4 years ago. And we've always maintained that they should be tied to COLA. And I also agree that creating a population of have and have-nots is never a good thing with a military benefit.
This question has been discussed in great detail and with some drama in my organization recently. After much discussion, the TRIA has found that we could agree to a COLA increase if that was absolutely necessary. Our people are dedicated. They are patriotic. They see the problems that are happening, but they see their problems and they see their situations, and this is a very hard thing for them to make the conclusion.
Mr. Kaufman, thank you very much for your question. The 13% increase is modest in some people's eyes, but there's concern in our group that that increase is too steep. A 13% increase in the Chinese military, as reported last week, can that be described as modest? I think the others would look at that the same way we're looking at a 13% increase. We participate in retiree activity days across the nation and overseas. We travel and meet with retirees at these opportunities that are on bases across the country. And what we have heard is the word grandfather. The grandfather word might be something that we would be attracted to, and we would certainly give it our very serious consideration. Thank you, sir.
Mr. Cobbett, thanks for the question. I believe there's less opposition to what you're, or less concern in our association to what you're proposing than the current DOD proposal. But I have to state again that the oversight responsibility on this issue is key. DOD currently has the authority to adjust these fees apart from the USFHP part of this, which requires a legislative change. That goes back to 1995 when TRICARE was established. So I think key to that, to answering this question, is consideration of those key aspects. Thank you.
Congressman, I think we would have a hard time objecting to what you propose. We would put the caveat in there that we think it's important to put those principles in legislation to specify that the benefits or the health care package and retirement package is the offset to conditions of service, and that those in fact constitute an upfront premium, and that is why the COLA adjustment is reasonable. Is that a better deal than civilians get? Yes, it is. But civilians don't have to pay that upfront premium.
Thank you, Mr. Chairman. I yield back.
Thank you very much. Thank all of you. And I want to thank Congresswoman Vicki Hartzler of Missouri, who had been here, but she had a 9 o'clock meeting, and so she's just been a very valuable member of this subcommittee. As we proceed, in agreement with the ranking member, we'll go through another round, and we will be asking a question each. The question I have for all of you, and we'll begin in the reverse order with Ms. Cook, and that is the proverbial question of pharmaceuticals. Should they be mail order or should they be by pharmacy? I know that I found it very helpful to have a one-on-one contact with the local pharmacist. And so not only could you let me know what you think about the mail order, but are there ways to reduce cost by using the local pharmacy?
I think there's a role for mail order. I think for beneficiaries who are on several routine maintenance medications, it may be more convenient for them to have those medications delivered to their home. But there are circumstances, certainly for urgent conditions, where having a relationship with a local pharmacist and being able to access those medications on a timely basis are critical. So I think there's not a one-size-fits-all. I think to the extent that home delivery for maintenance medications is something that really should be considered, because I think it would save the department money, but it could not necessarily offset people's right to receive urgent medications or exercise their options to receive it at the retail. So I think there's room for both.
The Military Coalition has worked hard with DOD Health Affairs to try and get beneficiaries to shift over to the mail order system, and they are finding immediate savings by accomplishing this. And so ROA, of course, supports this type of move, and to personalize it, both my parents, who are in their late 80s, love the system because it saves them trips and constantly reminds them for refills. But as was pointed out in both my testimony and by my compatriot to my left, having some type of way that individuals aren't penalized when they have to go to a retail side with higher copayments is something we have to explore and I think include in any type of system that we go to, so that young families that have to do a late night run to stop an ear infection don't pay higher prices just because they want to take people who have maintenance drugs and move them over to the mail order.
One of the things that we've discussed, of course I agree with the statements of the two previous panelists, but one of the things we've discussed is education of the beneficiaries on how easy it is to use the mail order pharmacy. because people are reluctant. They're worried that they're not going to have enough pills. It can be difficult to make that initial start, especially if you're getting your prescription from a medical treatment facility. But we do believe that not penalizing those service members and family members who need that urgent medication or need a narcotic that they couldn't get sent through the mail order, they shouldn't be penalized with increased fees. But we do believe that the fees will promote greater efficiencies overall if more people use the the mail order pharmacy for their recurring medications.
I agree with everything that the previous three people have said. I will also say that speaking to a pharmacist can be very helpful, particularly with an initial prescription. And it's helpful if you're at the MTF. It's helpful if you're at a retail pharmacy. So I think it's obvious that we need both in the system. But for continuing maintenance drugs that you're taking for years and years, of course, the home delivery is a very useful option.
Home delivery is a useful option, and it saves the beneficiary and the Department of Defense taxpayers money. However, one of the things that could save money for the Defense Department, and we feel is a primary reason for the higher costs in the pharmaceutical program, is the lack of aggressiveness in pursuit of the federal pricing schedule for drugs they used in the department. Some years ago, we offered the opportunity for federal pricing. It was projected to return $1.6 billion annually. Well, the lack of aggressive nature of the Defense Department in securing federal pricing has resulted in 1/3 of that amount being received, well, $600 million. So we need a little more aggressive action on the part of the Defense Department and a little less blame on retirees.
And I apologize, Mr. Barnes, but my time is up. And so I now proceed to Ms. Davis.
Thank you. I wanted to just turn to some of the transition programs really quickly, because I know that a number of programs have been developed to respond to wounded warriors and their families. Yeah. But when I speak to people, I always have the feeling that something's not quite connecting. So if you could specify as quickly as possible, where do you see those that gap? What's the problem? I think that we've also identified, I think a number of you did, in the data systems and being able to go from the DOD to the VA. But I'm just wondering, is there something about the way the service could be improved that would enable that transition to be much smoother when it comes to our families?
Are you talking about the transition between DOD and VA, or
transition back to the community?
Back to the community. One of the things that we've talked about consistently that is a chronic problem is mental health, behavioral health. DOD has made great strides. I mean, everybody and his brother is trying their best to do these kinds of things, and to try to find ways that it can be done and delivered in a way that the beneficiaries are comfortable with. There's a lot of fear on this issue. The service member is concerned that if they identify themselves, they're going to hurt their career, in many cases with good reason. The family members are reluctant to come forward for fear of the impact on the service member, for fear of being stigmatized. There are programs underway to try to do those in ways that are not reported back to the Defense Department. Those get more participation, but they don't identify the problem to DOD. So there's a chronic issue, and I have to think that the key is going to be the destigmatization effort. And I think we have a problem with the senior leaders talking destigmatization, but when it comes to the unit, if you come forward, you are stigmatized. And until that changes, until the action matches the rhetoric, I think we're going to continue to have a problem.
Congresswoman, excellent question. I would echo Steve's concern, and I will tell you from my experience when I was on active duty, having something about counseling in my record, it was like you just don't go there. And this stigma issue is huge, and it's going to take a long time to turn that around. Another aspect of this is family readiness, awareness of programs. Despite significant resources being committed to these across the services in the Department, we still hear story after story about spouses, family members, and sometimes service members that are not aware of programs and services that are available to them. Going back to the seamless transition issue, which I have to do a plug here, the bureaucratic challenges associated with the Department of Defense and the Department of Veterans Affairs for these wounded warriors and what they have to deal with is still very challenging. The Special Oversight Committee is faltering, great concept, but oversight is needed continually on this, and there needs to be a lot more done to affect seamless transition, take care of these wounded warriors and their families.
One challenge that we have, ma'am, is the duration that individuals are placed in these transitional programs. In some cases, individuals are discharged as being fit when not all of their problems are recognized and recorded. In other cases, you have individuals who are kept on medical hold because of the duration it takes to go through medical evaluation boards and physical evaluation boards. So these are things that need to have oversight and review because it's not doing justice to our young warriors.
We'd also like to look at some bridge programs for our service members who are and families who are being medically retired or medically discharged. Our association has promoted the idea of a 3-year active duty benefit for those service members who are medically retired. We know they're still eligible for TRICARE as a retiree, but it would be similar to the survivor benefit. It would help them in those transitioning years with costs, with letting them use a system that they're familiar with as they transition into the community. We're also, I know we haven't talked about families with special needs, but perhaps providing 1 year of an ECHO benefit for those families with disabilities, be they a wounded family that's being medically retired or even a retired family after 20 years who hasn't been able to settle in the community where they're going to make their final retirement.
Thank you all. And Congressman Allen West of Florida.
Thank you, Mr. Chairman. I'd like to go back to the question that I was previously asked, because I know there were some people that wanted to respond to that. Because I think that when you look at the nature of military service, it really is Pavlovian in nature. I mean, we do reward people for the right type of behavior. So, I really believe that if we're, serious about how we can lower the cost for military retiree health care, then how can we make sure that military retirees are healthy? So I know that there were some people that still want to, chime in on that. So please.
Yes, sir. It's an excellent question, and we appreciate the quotation from Washington. We used the quotation in our testimony and thought that the perception was so key that we all should be able to recognize that. And that the nation does, those who will be coming into service tomorrow do reflect on how today's veterans and military are being treated. You asked a question about how do we encourage individuals to maintain their public health, maintain their individual health. And you mentioned smoking and running and those sorts of things which are key. Well, we do that not necessarily by government, but we do that necessarily by example and by appreciation. We note a lack in our communities of a community sense, of a community spirit. We see it with the litter on the highway. We see it with a lack of appreciation for people who excel. We see it for all sorts of things. What we're looking for is something like what was given with apologies to Nikki Tsongas of Massachusetts. Some years ago, Michael Strahan retired from football, New York Giants. They had just won the Super Bowl, beating the previously undefeated Patriots. And Strahan was speaking with George Mara, the president of the Giants. And Mara said that Strahan thanked him and thanked the organization for all they had done for him. And Mara simply said, it's not the organization that should be thanking. He said, I think you have done more than we can ever do for you. that is the example of excellence, and that's the example we need to have reflected in our communities. We know that there are, 20% of Americans today are not ready physically to become a service member. We need to incorporate physical education in our schools. We once did, in my youth certainly. I'm not sure in your youth, sir. But in my youth we had physical education, and it was a regimen. People enjoyed it. Dodgeball was a fun game. It wasn't... you hit in the head once, you learn the game better. You always learn how to play the game a little bit better. But these are the things, it's the community, it's that sense of community and understanding and example, and you set a fine example. And there's so many other Americans today who are setting that example, and we try to do that with our preventative care in the hospital system to encourage people to take the right course. Certainly we save a lot of money in insulin and diabetes and those sorts of things that we can capture it early. So these are the things that, and I appreciate you giving me the opportunity to speak on this issue. It's very important. We do it by example, not necessarily by government.
Congressman, I would thank you for your service and thank you for the question. A couple observations here with regard to your description of the VFW hall and the smoking is indicative of a demographic issue. We in our association are working to communicate with 3 generations, in essence, those currently serving and those in between and those that have that go back through a number of conflicts into World War II and some before that. And communicating to them education awareness is key. The communications aspect of this goes to the use of the mail order pharmacy issue. 2, awareness is a great deal of anxiety in certain demographics about trying something new and whatever. I will tell you I'm enrolled in the medical home at Bethesda, and there are new efforts that are trying to be implemented, communications electronically and what have you, to help address some of these things. But I think the starting point is understanding the demographics and the perceptions of these different groups and trying to communicate and educate them about the importance of healthy lifestyles and changing some bad habits.
Well, thank you, and Mr. Jones, I will absolutely agree with you. It is leadership by example. That's the key thing. So next time I'll ask Mr. Chairman if he'll join me at 5 in the morning for a 6-mile PT run. But thank you very much, and I yield back.
Will take you up for a 5-mile walk. I've got my pedometer. And we'll be concluding with a question from Congressman Mike Kaufman of Colorado.
Thank you, Mr. Chairman. What maybe you all could give me some examples if we were to focus on the delivery process, and I'll include the family health care individual in there as well. What specific changes do you think we could make to contain the cost? In other words, is there room to maneuver in terms of saying that there's got to be some kind of primary care gatekeeper that one has to see before accessing a higher price specialist, particularly those people outside the network, and that might be sort of the Kaiser model of a nurse practitioner or a physician's assistant. I mean, are we doing enough in terms of cost containment at that level, particularly in primary care? Let me start with from the U.S. Family Health Care Plan.
From a delivery process, I think it's less about the gatekeeper, it's integration. So almost 100% of beneficiaries enrolled in our plan have a primary care manager, and it's the credibility and trust of the relationship. So it eliminates duplication of services, so that's one cost-cutting measure. There's a relationship there, so there's not a knee-jerk reaction to send a beneficiary off for specialty care or to send them off for urgent care or emergency room visits, when in fact they have a primary care physician that understands their medical history and can provide that care. So I think that's critical. It is also there's a value in understanding the complete picture of the beneficiary, not just having access to their inpatient or primary care claims. It's really understanding what medications the beneficiary is on, utilizing health risk assessments, engaging the beneficiary in their health. And
let me ask you, I'm sorry to interrupt you, but time is short. so that if I'm a benefit, and I will be soon, I've just received my letter for TRICARE. And so let's just say I make a decision that I think I've got diabetes, or there's something wrong where I want to see an endocrinologist, and I make that assessment. Can I do that? Can I make that decision myself and access a specialist?
Not according to the TRICARE Prime benefit, so
Okay.
you would have to receive a referral. But again, if you were enrolled in a program that has a diabetes care management, disease management program, even if you didn't raise your hand, you would be identified and sought out for active participation and have that managed.
Because I think that's one of the issues in terms of escalating healthcare costs is when you don't have a primary care gatekeeper there and people are making decisions about accessing, that have direct access to specialty care without going through some type of gatekeeper process that says, we can really do this at a lower cost here at this level instead of seeing a higher cost specialist. Does anybody else want to comment on that?
As Ms. Cook pointed out, TRICARE Prime across the board with all the contractors has primary care managers that try and control this. We've been briefed by DOD that the real cost that they're facing isn't so much the care that comes out of that program, but by the fact that so many people who are beneficiaries go directly to emergency care.
Okay.
Pops the care way up, and they're trying to find ways of bringing urgent care centers and other ways of doing it to reduce the care there.
Okay, good point.
I think it's also interesting, our association, of course, is a big promoter of TRICARE Prime, but TRICARE Prime is not the entry to the benefit. We have so many of our beneficiaries who are not enrolled in TRICARE Prime, either because of geographic reasons or they choose not to be, but who are in TRICARE Standard. And I think it might be interesting to contrast those who are in TRICARE Standard who may be cobbling together their medical care and contrast their costs, and mostly which are out of pocket, but there is a cost to DOD, with those who are in managed care and have primary care managers.
Okay.
Congressman Kaufman, I think one of the big problems, that we've sort of touched around here is that Department of Defense spends a lot of time on TRICARE Prime. We talked before about this subcommittee's effort to put something in law requiring DOD to establish these healthy care kinds of programs, which they did for TRICARE Prime, but they don't have those kind of chronic condition programs for TRICARE Standard for the people over 65 under TRICARE for Life. Yet we know who the diabetics are. We know who the high-cost people are. To us, there's a great opportunity to reach out to those people, not to control their care, but to urge them to participate in these kinds of management programs.
Thank you. And I just want to assure Lieutenant Colonel West that what happens in the VFW hall stays in the VFW hall. I yield back, Mr. Chairman.
Thank you very much. Thank all of you. And at this time, Ms. Davis, if there's no further, pardon me, please.
Thank you, Mr. Chairman. I just would certainly invite all of you. I think you have a lot more to say about this issue and how we work some of this and some of the questions to ask. And so we certainly welcome you to, if you'd like to put some of that in writing, to do that or to communicate with us in whatever way you prefer in our offices. I really appreciate the fact that we have to work through this, and I feel as if I don't have as good of information from the DOD as we might like to understand better the real impacts on some of this, and whether or not we actually are, it's not so much comparing apples to oranges as much as understanding the impacts that some of these changes may bring about, and in fact, whether we're doing all that we can in terms of this prevention issue. If we're doing what I think Ms. Cook has said, and we're trying to bring about many of those economies of care and making for healthier people through this, then it ought not cost so much more. We ought to find a better way to do that, and I'm hoping that we can work through this as we move forward. Thanks a lot.
Thank you, and I want to join in with Ms. Davis that all of the members of the subcommittee are available and want to hear from you, meet with you. Also, I want you to know what an extraordinary resource we have with Jeanette James. She herself has been a nurse, and so we're very grateful for her service on the as the professional staff working with John Chappell. What a great team. And so BMI graduate. So we're very grateful, and at this time we shall adjourn.
Thank you, sir.